topic of discussion today is BIS versus end-tidal anesthesia gas monitoring to prevent intraoperative awareness. Why I have chosen this topic? Intraoperative awareness with recall, while rare, is a distressing complication of general anesthesia that is associated with significant psychological sequelae. Since the introduction of curare and other neuromuscular blocking drugs, intraoperative awareness has become a significant anesthesia concern. But this topic is rarely discussed. Therefore, I chose to talk on this topic. We will go through the following important points related to intraoperative awareness. First, we will see the incidence and psychological sequelae of intraoperative awareness. Next, we will see what are the monitoring gadgets to assess the depth of anesthesia. We will discuss in detail about BIS and end-tidal gas monitoring, as these are widely studied and has ample literature to support its use. As we have resource constraints in India, we cannot use these costly monitors in all the cases under general anesthesia. Therefore, we must know factors associated with the awareness, may it be patient factors, surgical factors, anesthesia technique, or anesthesia drugs. Lastly, I will share few points of practical utility. Intraoperative awareness with recall refers to intraoperative consciousness in cases in which unconsciousness is expected and post-operative explicit recall of operative events. Reported incidence is only 0.1 to 0.2% of all general anesthesia cases, which is approximately 1 to 2 per 1,000 general anesthesia cases. It means it is a rare complication, but it can be potentially devastating. Anesthesia is compared with aviation, and we can learn many things about patient safety from aviation. Let's see one example which can correlate with the rareness of intraoperative awareness, which is ditching in aviation. In aviation, ditching refers to controlled emergency landing of an aircraft on water when landing on a runway is not possible. It is a rare occurrence, typically performed when facing critical emergencies that compromise the aircraft's ability to fly safely, such as engine failure or structural damage. The incidence is very low, which is 0.00003% of all the flights which fly last year in 2025, and the number was 40 million flights. So it is very rare event. This is famous picture of ditching event, which became known as the Miracle on the Hudson. What was the event? It was a successful emergency water landing after the plane's engine were disabled by a flock of birds shortly after takeoff from airport. And the captain of US Airway Flight 1549, Mr. Chesley Sullenberger, became famous for his extraordinary skill in landing on the Hudson River on January 15, 2009. After the incident, Captain Sully said, "In aviation, the margin for error is narrow. The better you are, the more aware you must be of what you don't know." He emphasizes humility in mastery, acknowledging that further improvement is always possible and essential, especially when things appear to be going well. Why I am quoting this? Because we are already masters of our profession, and similar to aviation, anesthesia is safe. At the same time, there is room for improvement, particularly in the area of intraoperative awareness. Let's see the psychological sequelae of this rare event. A large proportion of awareness survivors develop post-traumatic stress symptoms. For example, one prospective study found that 43% of aware patients screened positive for PTSD symptoms versus 16% of controls. There are long-term impacts which include symptoms like nightmares, insomnia, daytime anxiety, and flashbacks. Affected patients often report severe distress and reduced quality of life. Litigation and malpractice claims are rising in part due to awareness cases in the United States. Other sequelae are depression, phobias, substance misuse, fear of future surgery. Some patients avoid needed surgery afterward. So the expert opinion stresses that even a single awareness event can have considerable potential for severe emotional distress. In my practice of last 20 years, this is the case who recalled everything that happened after I gave her general anesthesia. She was 40 years young lady and was posted for kidney transplant. I gave her thoracic epidural and she was induced with routine drugs like fentanyl, propofol, and intubated under atracurium. After induction, full dose of epidural was given for analgesia. Because of CKD, her pressure was already high and she was also having tachycardia. Then once surgery started, her tachycardia and blood pressure didn't settle. Her muscle relaxant requirement was very high and she required top up every 15 minutes. Her hemodynamics responded well to propofol boluses. Surgery was uneventful and we extubated patient and shifted her to room. Dr. Swati was with me. She went with the patient to her room where patient told Swati that she was able to listen all the things in operation theater but could not move or communicate with us. She was frightened. Throughout the surgery, we didn't suspect intraoperative awareness. Now we looked for causes and what we found was awareness due to improperly placed vaporizer. Can you guess what's wrong here? The vaporizer is slightly tilted towards left. You guessed it right. Isoflurane vaporizer was not fixed properly. Vaporizer is slightly tilted towards left, not much. Actually, this vaporizer is shifted from one OT to another wherever it is required. Somebody fixed it on the dragger machine, but it was not fixed properly. And isoflurane was not delivered to breathing circuit at all, leading to complete intraoperative awareness. Here the vaporizer is fixed properly, but I guess it was too late. When there is a concern for possible intraoperative awareness, the modified Bryce questionnaire shown in this slide is useful in characterizing the event and has been shown to be more sensitive in detecting intraoperative awareness with recall compared with other methods. Even though rare, awareness is a never event given its devastating impact. Zero tolerance. ASA advisory guidelines urge preventive strategies in at-risk patients. Clinical reminders are not good predictors of intraoperative awareness, like the blood pressure and heart rate changes or the patient movements. So we should rely on multiple monitors. Quality improvement helps to prevent awareness and avoids costly sequelae. For instance, one cost analysis noted that BIS monitoring in high-risk cases could prevent one awareness and its cost for roughly around $2,200. This highlights the importance of vigilance despite low incidence of intraoperative awareness. There are a number of brain function monitors that use proprietary algorithms to process the EEG and provide the data to anesthesiologists with a value intended to represent the depth of anesthesia. In addition to the BIS monitor, other monitors include Entropy, Narcotrend, there is SedLine also, but BIS being the most widely used one. Entropy monitors analyze a single lead frontal EEG, typically using a sensor with 3 electrodes placed on the patient's forehead. The monitor generates two indices, state entropy and the response entropy. The state entropy represents the hypnotic level of patient and reflects the degree of unconsciousness induced by anesthetic drugs, while response entropy reflects the response to noxious stimuli, including upper facial electromyography. The Narcotrend is an EEG monitor designed to measure the depth of anesthesia and sedation during surgical procedure as well as in intensive care unit. It works by automatically classifying the EEG signals to determine the patient's level of hypnosis. BIS is a processed EEG indicator of hypnosis where 0 denotes the isoelectric state while 100 denotes the fully awake patient. The BIS uses frontal EEG electrodes and signal processing. BIS can be used regardless of anesthetic type, whether it is inhalation anesthesia or the TIVA. A BIS value of 0 represents persistently suppressed EEG activity and 100 indicates a fully awake state. A target range between 40 to 60 is the proposed range in which patients have a lower risk of experiencing intraoperative awareness with recall during general anesthesia. There are limitations of these artifacts. The facial EMG, like if the patient is shivering, adds high frequency noise and it falsely causes rise in the BIS value. Even electrocautery or ECG signals can corrupt readings. Proper electrode placement and filtering are very important. These neuromuscular blocking agents paralyzing patients removes EMG, which can paradoxically cause BIS to read very low, even if the patient is light. One must be cautious. A BIS of 40 in a paralyzed patient might still indicate adequate anesthesia, but false lows do occur. There are drug confounders, like the ketamine induces a unique EEG pattern. There is high frequency desynchronized waves, often elevating BIS despite deep dissociative anesthesia. Similarly, nitrous oxide can suppress the delta waves and paradoxically raise BIS. Thus, BIS may not accurately reflect hypnotic state with these agents. There are other issues like poor electrode contact can give erratic readings, low cardiac output or hypothermia can also blunt EEG and alter BIS unpredictably. So in summary, BIS is a useful guide but must be interpreted in context of patient history, drugs or electromyography. A BIS monitor costs around 3 to 3.5 lakhs in India. The disposable BIS electrodes cost is around 1500 to 2000 rupees. So awareness is rare. Therefore, in low income or resource limited settings like many hospitals in India, the high cost of BIS equipment is a barrier. Instead, maintaining adequate volatile anesthetic dosing and using simpler monitors like capnography and the MAC alarms may be more realistic. The ASA and other bodies emphasize risk-based use of BIS, especially when funds are limited. Awareness is rare, so cost effectiveness depends on risk. In high-risk surgeries, studies estimate that cost to prevent one awareness is few $1,000s. The continuous capnogram measures the end-tidal volatile anesthesia agent concentration, which reflects the brain anesthetic partial pressure. So this is end-tidal anesthesia gas monitors also help us to assess the depth of anesthesia. This end-tidal anesthesia gas monitoring relies on calibrated gas analyzers attached to the breathing circuit. This accuracy depends on no circuit leaks, correct gas calibration, and it is irrelevant in total intravenous gas anesthesia. Here you can see the inspiratory as well as the expiratory value of the isoflurane is shown, and lower down the screen you can see the MAC of 0.6 is shown on the patient's monitor screen. We know what is MAC. MAC is a minimum alveolar concentration at 1 atmosphere that prevents movement in 50% of patients exposed to a surgical incision, and MAC decreases with age. If we want to use inhalation anesthetics to prevent intraoperative awareness, then we should use end-tidal anesthesia gas monitor for correct MAC values. MAC values are calculated from expired end-tidal concentration of anesthesia gas and the age of the patient. So it is a calculated value. These are the end-tidal anesthesia gas corresponding to the MAC of 1. So halothane has a MAC of 0.75%, isoflurane 1.4, sevoflurane is 2. So if you have a expired anesthesia gas concentration of 2% for sevoflurane, that means the patient's MAC value is approximately 1. These are the age-adjusted MAC values. You can see here, the pediatric patients require high end-tidal anesthesia gas concentrations to have MAC of 1. As age progresses, lower end-tidal anesthesia gas concentrations are required for maintaining MAC of 1. Here, I would like you to note that if you don't enter age of the patient on monitor, then the MAC shown on the monitor will be for the age of 40 years. So irrespective of the patient's age, if you don't enter the demographic data of the patient on the monitor, then the MAC displayed on the monitor will be for the age of 40 years. Now, this was all about the various monitors and their pitfalls. Now, we will go for the references regarding effectiveness of BIS and other EEG monitors in preventing intraoperative awareness. Be Aware trial was conducted in 2004. In this RCT of 2,463 high-risk patients, BIS targeted anesthesia reduced awareness compared to the clinical care. This was the first large study which established usefulness of BIS in preventing intraoperative awareness. But in 2008, we got this Be Unaware study, which was published in the New England Journal of Medicine. They studied 2,000 high-risk patients randomized to either BIS versus end-tidal anesthesia gas with alarm group. Both groups had 2 cases of awareness, so the incidence was 0.2%. No statistically significant difference was found in these 2 groups. BIS did not reduce anesthetic dosing in this trial. Use of BIS protocol was not associated with reduced administration of volatile anesthetic gases. Anesthesia awareness occurred even when BIS values and end-tidal anesthesia gas concentrations were within the target ranges. Their findings do not support routine BIS monitoring as part of the standard anesthesia practice. To clear the confusion about effectiveness of BIS or end-tidal anesthesia gas monitoring, we can refer this update on BIS published in 2018. This Cochrane Review article has included 36 trials with 7,761 patients in BIS group and 26,530 patients in end-tidal anesthesia gas monitoring group. Author's conclusion is BIS-guided anesthesia can reduce the risk of intraoperative awareness in surgical patients at high risk of awareness in comparison to using clinical sign as a guide for anesthesia depth. BIS-guided anesthesia and end-tidal anesthesia gas monitoring guided anesthesia may be equivalent in protection against intraoperative awareness, but the evidence for this is inconclusive. So you cannot differentiate the superiority between one of them. In addition, anesthesia guided by BIS kept within the recommended range improves anesthetic delivery and post-operative recovery from relatively deep anesthesia. Another important conclusion of this Cochrane review is, irrespective of the anesthetics used, BIS reduce the following recovery times, that is time for eye opening, response to verbal command, time to orientation, time to extubation, and the post-anesthesia care unit time. So these are all positive conclusions for the use of BIS in clinical practice. So there are recommendations or there are cost constraints to use the BIS or end-tidal anesthesia gas monitoring systems because of the high costs. So now we are coming towards the last part of my presentation, that is the factors associated with risk of intraoperative awareness. First, we will see patient factors, and these are ASA grade 4 and 5 patients who have limited cardiac reserve, patients with chronic pain or high opioid use, they usually have tolerance to these drugs, substance abuse, prior history of awareness, anxiety history increases the risk. The pediatric patients have higher incidence of intraoperative awareness. Coming to the surgical factors for intraoperative awareness, the cardiac surgery incidence is 1 to 1.5%, cesarean delivery 0.4%, so these are high-risk patients. Trauma emergency cases where there is uncontrolled hemorrhage or there is airway trauma, these patients carry the highest risk. There are some reports which say that the incidence is 5 to 10%. So ASA guidelines explicitly list cardiac, then cesarean sections, trauma, emergency and high-risk surgical procedures for intraoperative awareness. These are the anesthesia techniques with high risk of intraoperative awareness. So general anesthesia with muscle paralysis dramatically raises the risk because patients cannot move to signal a light plane of anesthesia. Total intravenous anesthesia, particularly propofol infusion without volatile anesthetic agents, has higher awareness rate than inhalation general anesthesia. Regimes using only nitrous oxide and opioids without any hypnotic agent will also increase the risk of intraoperative awareness. There are few preventable factors. We electively give inadequate dosing to keep patient light so that we have improved hemodynamics, like in trauma patients, where if the patient's blood pressure is on lower side, we try to decrease the MAC so that patient's blood pressure will improve. Patients who are bleeding profusely, so this increases the risk of intraoperative awareness. And I have already shared the case of intraoperative awareness due to equipment failure. So equipment failure is another cause. Apart from improperly fitted vaporizer, which I have shown the picture, there is also increased risk with empty vaporizers or if there are errors in the gas flow. Anesthesia gas monitoring are very useful to know the correct delivery of inhalation anesthetic agents. In TIVA cases, IV line disconnection can cause intraoperative awareness. Let's see the anesthesia drugs which are associated with increased risk of intraoperative awareness. I have already mentioned that neuromuscular blockers significantly increase the incidence because they mask the patient movement. Single agent propofol infusion has higher recall risk than volatile anesthesia. Use of benzodiazepines. So this is very interesting. Use of benzodiazepines at induction or maintenance greatly reduce the intraoperative awareness. Ketamine and nitrous oxide distort the EEG monitors, which can mask the light anesthesia. And high opioid techniques without any inhalation anesthetic agents also increase the risk of recall unless you use either BIS or other similar monitors. So, to conclude, the routine use of BIS is not advocated, but BIS is definitely useful in high risk patients in TIVA and significantly improves the recovery time and the extubation time. So, this is particularly useful in airway surgeries, in OSA surgeries. The end-tidal anesthesia gas monitoring is equally effective to monitor the depth of anesthesia. During end-tidal anesthesia gas monitoring, always set the audible alarm to indicate when the gas concentration falls below 0.7 MAC or it exceeds the 1.3 MAC. This will reduce the risk of intraoperative awareness. Remember that MAC is age dependent, and unless you enter the correct age of the patient on the monitor, it will not calculate the correct MAC for your patients. If you compare the cost between BIS and end-tidal anesthesia gas monitor, this end-tidal anesthesia gas monitor, the overall cost to the patient will be less. The single incidence of intraoperative awareness taught me that in anesthesia, the margin of error is very narrow. The better you are, the more aware you must be of what you don't know. So I thank you all.